Hello. Uh, Today we are going to talk about respiratory system pathology. I'm Dr. Mohit, and we shall be discussing a few things today. We shall begin with the anatomy of the respiratory system. As we all know that it starts with the bronchus, and the bronchus divides into a pre-terminal bronchiole, which further divides into a terminal bronchiole, which then further divides into a respiratory bronchiole. Then they can finally divide into alveolar duct and into the alveoli. This is how it actually looks like. You can see here this, I'm sorry, you can see here right over here, this part is the segmental bronchus. This is the large segmental bronchi. This is the, then it goes into a small segmental bronchi, and finally you get what you get here is a bronchiole. And if you look very carefully, this part is devoid of cartilage, whereas this part has a lot of cartilage. Other histological feature which differentiates a bronchi from a bronchiole is lack of submucosal glands. Yes, right. So these submucosal glands are missing after the bronchi, and this bronchi further divides into a terminal bronchiole which has a respiratory bronchiole, and finally they get divided into these smaller air holes which are called as alveolar sacs and alveoli. The concept of what is an acini and what is a lobule is very important over here, because this concept is important as we are going to discuss about emphysema in the next presentation. So this acini basically is nothing but a respiratory bronchiole along with the alveolar duct and the alveoli. So when you have these three components, which is let's write it over here, you have a respiratory bronchiole, plus you have the alveolar ducts, plus the alveolar sac, the exact final thing where the gas diffusion actually keeps. So this whole thing is equal to one acinus. So these multiple of these things, you have a group of acini will be called as a lobule, whereas this part is called as the acini. So we have to understand this concept of acinus and lobule, and we should be able to differentiate between the bronchus and the bronchioles based on the histology as well. Now again, you can see over here, this is having the cartilage. This is the bronchi. I'm having the cartilage, smaller bronchi, which is about 15 generations or 5 generations and so on, and finally it divides into these bronchioles, and you can see these outshoots from these bronchi, from these bronchioles. You have the terminal bronchiole, you have the respiratory bronchiole, and you have the alveolar ducts, and finally you have these alveoli. So this part is the acinus, right? So these are the small alveolar spaces which are separated from each other with the help of this interstitial space, and this interstitial space mainly consists of the main component. Yes, the main component would be elastin. Yes, because the lungs have to recoil after every inspiration and expiration. The lungs are supposed to recoil. So we have to have this this area should have elastic fibers. Along with that, they also have some mast cells. They have capillaries, of course. They have capillaries where the gas exchange actually occurs, which we shall be discussing in a short while. So here we have the respiratory bronchiole, the alveolar ducts, and this acinus. Why am I laying so much of stress on this acinus and this part? Is because in emphysema we are going to discuss this thing again. So I would like you to understand this concept of a acinus and a lobule. So this part is an acinus, and if you include the terminal bronchiole, because many such acini which include respiratory bronchiole, so if we include the terminal bronchiole, this whole thing is called as a lobule, which is present over here. Right. At the same time, I forgot to mention over here, you can have a look at these small pores which are present here. These are the holes through which things can be exchanged between two alveolar sacs. That means the exudate, in cases of inflammation, it can come from this pore of Kohn and may go into this alveoli and this alveolus, and things, the bacteria can so that is how things can actually get, they get distributed, they get disseminated throughout the whole acinus and throughout the whole lobule, and finally may involve the whole lobe. Lungs anatomy, as you are quite pro in the anatomy part, we have right lung, which is comprised of 3 lobes. We have left lung, which mainly has an upper lobe and a lower lobe. Yes, they have 2 lobes. So we have 2 fissures in the right lung, and we have 1 fissure in the left lung. The weight of the lungs is around 1000 grams, around 1 kg. So that makes it slightly easy to remember. I'm just rounding it off to a nice figure. Lobes, right, we have 3, we have 2 in the left. Segments, we have bronchopulmonary segments, you have the bronchi, you have pulmonary and bronchial arteries. Bronchial arteries and the pulmonary arteries they actually follow the bronchopulmonary segments. The veins are slightly independent. At the same time, you have the viscera, which is you have the pleura, which is visceral as well as parietal. And one important thing which on autopsy we have always been hearing, that the pleura should be glistening, that it should be shining, a brightly shining lung. So this visceral pleura should be quite a shiny thing, which what we should be looking. If it is not shiny, if it is having some kind of haziness or some kind of it's not really clear, it's not really glistening, then we have to look for some reasons why it is not glistening. Then we have the nerves. Now, what happens if, let's say, the weight of the lungs increase? Let's say the weight of the lung, normal weight of the lungs is, you have somewhere around 550 gram is the right lung, and you have the 450 gram is the left lung. Now let's say if the weight of the lung increases to around 2000 gram, what will happen? What do you think is the reason? The reason is there is decrease in the air and increase in something which has come from outside, right? It can be exudates, it can be water which is present inside the lungs. So these things will make the lungs heavy. Now if the air is being replaced by the exudates, that means the lungs will not have that sponginess anymore. So if you press this lung, if you palpate this lung on autopsy, that bubbly feeling of the air passing through some substance will not be there. That means the crepitance will go down. And if crepitance goes down, what will happen? Crepitance, that means the crepitance is no more air is there. So that means the crepitance goes down, the lung has reached a phase of solidification, and the technical term which we use for solidification is actually called as consolidation. Consolidation. I will be seeing that in a short while. So this crepitance, if it goes down, that means instead of air, you have something else in the lungs. So that means lungs air spaces have been replaced by exudates or something else, which have, it's something just solid basically, not water. Because if it is water, the things, it will be heavy, but it will not be crepitant, of course, anymore. Now you have these histological section in which you can see different bronchioles, terminal bronchioles, alveolar ducts, alveoli. Should be able to differentiate on histology. Two important things which we have to mention here are this type 1 pneumocytes, type 2 pneumocytes. We have type 1 and type 2 pneumocytes. Type 1 pneumocytes are the ones which are lining the alveoli. So in a respiratory tract, in a bronchial tree, it starts all the way from the bronchus, which mainly comprises of the columnar pseudostratified ciliated epithelium, but as it goes down, it turns into cuboidal, and finally into the alveoli. It is mainly a flattened epithelium, which is quite similar to a squamous epithelium, and that flattened epithelium is basically called as a type 1 pneumocyte. These type 1 pneumocytes are the ones which are lining the alveoli, and please do not commit this mistake that these type 1 pneumocytes are the one which secrete surfactant. The surfactant is produced by type 2 pneumocytes. Yes, the type 2 pneumocytes, which are granular cells. They look like macrophages, but they're not exactly macrophages. They are not at all macrophages. We have another macrophages which are called as alveolar macrophages anyways inside the lung. So these type 2 pneumocytes are the ones which produce surfactant, which keeps the lungs open, which keeps the alveoli open. So they have the function of providing a surface tension. And these alveolar spaces, the space between the two alveoli called as the interstitial space, contains the capillaries, and the place between the capillaries and an epithelium basically is the interface where gas diffusion actually occurs. The oxygen comes into the blood and the carbon dioxide is removed from the blood. A deoxygenated blood which has come all the way from the right heart will now be oxygenated with the help of these alveoli, which will oxygenate the blood present in these small capillaries. So you should be able to recall that the histology of the respiratory tract starts all the way from the columnar, reaches to cuboidal, and finally you have this type 1 and type 2. Here we have that type 1 epithelium, this is the alveolar space. You can see here this is a granular cell which looks quite similar to an alveolar macrophage, but no, it's not a macrophage. It is basically a type 2 epithelium, a granular cytoplasm, large nucleus. They have villi over their surface, which increases its surface area. And you have here on the left side of the screen, you have this capillary lumen, which is of course lined by endothelium. All the blood vessels are lined by endothelium. So you have one layer of endothelium, you have type 1 epithelium, and this is the interstitial tissue, right? This is the interstitial tissue where you will have elastic fibers, collagen fibers, fibroblasts, you have mast cells, you have all sorts of things into this interstitial space, right? So the phase which the interface between the type 1 epithelium and the endothelium is this, right? So this is the part where actually the gas exchange occurs, right? So you have this cell, this is the alveolus, this is capillary, this is endothelium, and you can see here this is the area which is the basement membrane. So this is basically the area where the gas exchange will actually occur during respiration. Yeah, we know about the embryology. It basically starts from the ventral wall of the foregut. You have this esophagus here. It divides into these lung buds, and they finally have around 6 weeks. They even have a trachea, and this trachea first divides into the right lobar bronchi and you have the left lobar bronchi. The first thing which divides is the right lobar bronchi. And if you see very carefully, if I have to look at this angle, the angle which is from the trachea, and then you have here, this angle is, well, not exactly a 180 degree, but it's quite an obtuse angle, quite close to 180 degrees. So it's quite close to 180 degrees, whereas this angle is almost a 45-degree angle. Now, what is the significance of this? Yes, the significance is during aspiration or during lodgement of any foreign body. There are more chances of the foreign body going into the right side of the lung than in the left side of the lung. So because that happens, we should be able to explain why things go into the right side of the lung and not in the left side of the lung. This is because this angle at the time of division of the trachea into the respiratory bronchi, the right lobar bronchi and the left lobar bronchi, at that time this is quite a 180 degree angle, whereas this is quite an acute angle. So there are more chances that the foreign bodies get lodged in the right side of the lung rather than in the left side of the lung. So foreign body lodgement is the main concept which you have to understand when we talk about the angles of right and left bronchus, right and left bronchi to the trachea. A wonderful chest x-ray. It looks amazing. It is very nice. You can see the costophrenic angles, you can see the heart shadow, you can see them nicely lucent. This is very nicely lucent lung field, which looks amazing. And you can also see now this lucency comes because of the air. Now if the amount of air in the lungs go down, and when can that happen? The amount of air in the lungs may go down when the amount of air in the lungs go down. Alright, this is a nice chest x-ray. You can see the costophrenic angle, you can see the lung fields are quite black, and these airfields these airfields are quite black because of presence of the air. So that means this is lucency. We have to talk about lucency. Now if the crepitance, let's say, goes down, that means the amount of air in the lung goes down. What will happen to the lucency? Yes, definitely lucency will also go down, and that particular area where the crepitance has gone down, lucency has gone down, will be whitish in color, will have these white patches wherever you have you have solidification or consolidation. So if you do percussion on that particular area, it will be less crepitant. If you take an x-ray, it will be less lucent. Now that happens because of lack of air in that particular area. Now this concept is important when we have to discuss about the inflammations and infections of the lungs, mainly the pneumonias. So in those conditions, we will see that how crepitance and lucency of the lung is affected. Plus you can see these white marks. Can you see these white lines which are present everywhere? Yeah, these fine white lines are basically the blood vessels which contain the blood. So if anything you see here, don't get scared. Why do you have these whitish worm-like lines? They are basically because of the blood vessels. Yes, right. Now it's easy to divide the lung diseases into three major types. Since we have three major areas inside the lung, so it's quite easy to divide them into three major areas. You have the diseases which affect airways. You have the diseases which affect the interstitial space. All these are those diseases in which you can see we're talking about all those restrictive lung diseases which will affect the interstitium. We will talking about the diseases which affect the blood vessels. It can be a pulmonary thrombus, a pulmonary embolism, pulmonary infarction, pulmonary hypertension. All the diseases will be affecting the blood vessels, and and then we have a major category of the diseases which will affect the airways. Of course, this is and, and these diseases are called as the obstructive lung diseases, and they have this a chronic bronchitis, emphysema, bronchiectasis, asthma, and under its category, right? So we'll be talking about all these diseases in our other presentations. So we have diseases which affect the airways, we have diseases which affect the interstitium, and finally we have the diseases which may affect the blood vessels. Now we shall be covering these four major topics. We'll be talking about the pulmonary infections, which is the major thing which we'll be discussing today. We'll be talking about restrictive and obstructive lung diseases. We have to differentiate between the restrictive and obstructive lung diseases, which is an important thing to understand. It has a very deep concept which we have to understand. Then we'll be discussing pathology of the pulmonary tuberculosis, and finally we'll be talking about a huge list of neoplasias of the lung. We shall be talking about that soon. Now coming to pulmonary infections, we have a huge list over here. So this list seems quite a short one, but when we talk about pneumonia syndromes, we have Lobar pneumonia, bronchopneumonia, we have pneumonias in the immunocompromised host. We'll be talking about lung abscess and tuberculosis. Now, pneumonia, as the word says, it may be confused with the term pneumonitis, which actually mean we have always learnt in a foundation block in general pathology that anything which is suffixed by itis is inflammation of that particular area. So in pneumonia or in pneumonitis, it is mainly the inflammation of the lungs, but the term is not commonly used. The main term which is used is pneumonia. So any infection of the lung which leads to inflammation of the lung is called as pneumonia, and it is quite obvious because our lungs are actually exposed to litters of contaminated air which is around us. Everything is contaminated around us. It can be pollution or all these bacteria, the viruses, all microorganisms are around us. So we are quite in a risky environment as far as lung infections are concerned. At the same time, we have a lot of nasopharyngeal flora around. All sorts of bacteria are present in the nasopharyngeal flora, and we tend to aspirate that flora into our lungs. So then why don't we fall sick? We don't fall sick because of a nice host defense mechanism, which we have, right? So these defense mechanisms can be something which is quite mechanical, or something which is related to your adaptive or your innate immunity. So if you have anything which goes wrong in any of the lung diseases, you may have some kind of loosened or weak defense mechanisms, and you are predisposed to lung infections more than the normal counterparts. So these are all those host defense mechanisms which are more or less mechanical in the nasopharynx. You have the nasal hair, you have the turbinates, mucociliary apparatus, immunoglobulin secretion, because it is a mucosa, so we'll have immunoglobulins A, basically IgA secretion, and this mucociliary apparatus is basically it produce mucus and will trap down whatever things gets into your lungs and will try to throw it out. Cilia will have the same function. They move actually in a retrograde fashion, and they will throw out the things if they enter your lungs. You have saliva, sloughing of epithelial cells, local complement production, interference from resident flora. You have cough, you have the epiglottic or the gag reflexes, the sharp angle branching of airways, right? So this is again an important defense mechanism. Of course, we have mucociliary apparatus, IgM, IgG, IgA, which is being produced. In the lower respiratory tract, you have alveolar lining fluid, you have surfactant, Ig, immunoglobulins, complements, fibronectin, you have cytokines, you have, of course, alveolar macrophages, which will take care of the lungs right deep down into the alveoli. You have polymorphonucleoleucocytes, which will be present into the interstitial space, and plus you have the cell-mediated immunity, because the cells will be taking care of your immunity. So whenever somebody has some kind of problem in relation to loss of cough reflex, in relation to diminished mucin or ciliary function, there are so many genetic conditions in which you may have diminished mucin or diminished ciliary function. One of the example of diminished ciliary function is Cartagener's syndrome. It's called as Cartagener's or Cartagener's, I'm not sure about the pronunciation. It's called as Cartagener syndrome, in which the patient has lack of mucociliary function. So cough reflux, when is gone, if the patient is, let's say, comatose, or the patient is under anesthesia or under the effects of alcohol, so all these things will actually predispose the patient towards pneumonias. Again, we have alveolar macrophage interference, which we have discussed earlier. So they will be able to interfere. So anything which happens, something which goes wrong with the alveolar macrophages, if something is interfering with the alveolar macrophages, they will be predisposing, because alveolar macrophages, as we all know, in all the organs, macrophages. I would like to mention here that lungs basically have their own macrophage system called as the alveolar macrophages. There are only a few organs which have their own alveoli, which have their own macrophages, and lungs are one of them, because we don't really have time for the monocytes to come there and then they get converted into macrophages. We better have the soldiers which are already fighting there, rather than hiring whenever they are required. Anything goes wrong with the vascular flow, anything goes wrong with the bronchial or the airflow, anything which goes wrong with the blood vessels. Of course, when you have some obstruction in the blood vessels, it will lead to ischemia, and of course ischemia leads to infections. You have bronchial airflow, when any kind of obstructions which also may lead to pulmonary inflammations or pneumonias. Some general principles or basic consideration, as I have discussed earlier: pneumonia versus pneumonitis. Pneumonitis is no longer used, so the major term which is used is basically pneumonia. Now you have to differentiate this from a lot of things. Can be injuries, obstructive diseases, restrictive lung diseases, vascular diseases, and so on. Why do we have to differentiate? Because almost all of these diseases may lead to pneumonias. So any kind of injury to the lungs, any kind of obstruction to the lungs, all these obstructive lung diseases, chronic bronchitis is known to cause pneumonias. Bronchiectasis is known to cause pneumonia. So all these obstructive lung diseases predispose a patient to pneumonias. You have restrictive lung diseases, you have vascular disease, so you have to differentiate. So this patient was not basically having pneumonia. This patient was having pneumonia because of a vascular disease, or this patient was having pneumonia because of obstructive lung disease, or this patient may be having pneumonia because of a restrictive disease, and so on. Now, the second thing which we have to discuss under this category is our neoplasms, the lung tumors. There's a huge list, a big list of neoplasms of the lung. Now, we have always heard, that inflammations can lead to neoplasm, inflammations can lead to tumors. Yes, right. This may happen here as well. You may have these inflammations which may lead to, metaplasia, which may lead to dysplasia, and finally it will lead to neoplasms. But we have to understand this concept that pneumonias are by no means a pre-neoplastic condition. You may have a bronchopulmonary dysplasia or any kind of dysplasia which may happen inside the lung, which may lead to neoplasm, but should not say that pneumonias may actually lead to neoplasm. That's not really right. Right. At the same time, there's one important thing here. Neoplasms, can they lead to pneumonias? Oh yes, neoplasms can lead to pneumonias because they can lead to obstruction, and we have seen that obstruction can lead to pneumonias. So all these neoplasms which are actually large enough and they are blocking an airway, those sort of neoplasms can lead to infections, inflammations, and may also lead to atelectasis of that particular lobe of that or that particular segment of the lung. Another important concept which we have to differentiate is between the lobar and the bronchopneumonia. As the name suggests, lobar, that means whole of the lobe will be involved, whereas bronchopneumonias are the one in which not the whole lobe, but it will be like focally, that it will be involving all of the lobes, or it may involve whole of the lung in a very in a spotted fashion. It's not a diffuse thing, but it's a very focal thing which is going to happen in bronchopneumonias. We shall be seeing the diagram soon, and you'll be able to understand what is the difference between lobar, or maybe I can just draw it over here and can. So if let's say this is lung and this is another lung, so if we have these lobes, so if this pneumonia is affecting one whole thing over here, the whole thing is getting involved, that means this is a lobar pneumonia. But if it is going to affect lungs like this in a very spotted fashion like this, that means we are talking about the bronchopneumonias. This is lobar pneumonia, like this is the bronchopneumonia. Now if we say that this particular type of inflammation or this type of pneumonia will lead to lobar pneumonia, or this type of pneumonia or this type of organism will lead to bronchopneumonia, that won't be right, because lobar pneumonia may start like a small patch, right? So if it starts like a small patch and will have appearance which is quite similar to a bronchopneumonia. At the same time, bronchopneumonias, when they are really at a bad stage, they may merge into each other. Slowly they will merge into each other, and once they merge into each other, whole of or the segment of the lobe may appear to be affected and will have a picture quite similar to a lobar pneumonia. So we don't have, it's just basically an anatomical or a radiographic classification to differentiate between lobar and bronchopneumonia. Clinically, they don't really have any much therapeutic significance is not really there. Second thing which we have to discuss is the second concept is interstitial versus alveolar pneumonias. Interstitial pneumonias are the ones which basically affect the airspace. So if this is your alveoli, these are the alveoli, and you can see this will be having some interstitial space between. So this is the interstitial space and these are the alveoli. So if the pneumonias are affecting this interstitial space, they are called as the interstitial pneumonias, whereas when they affect the alveoli, they are called as the alveolar pneumonias. I'm really sorry for the bad diagrams. I'm not really used to these digital pens yet, but slowly I hope I'll improve. So interstitial pneumonias are the ones which will be affecting the interstitial space, whereas the alveolar pneumonias will be affecting the alveolar space. What kind of organisms may lead to interstitial pneumonias and what can lead to alveolar pneumonias? It's a general principle that all the bacterial infections will be basically alveolar, whereas all the viral and the atypical infections will be interstitial. That means the community acquired pneumonias will be alveolar, whereas atypical pneumonias, viral pneumonias are the ones which will be affecting the interstitial space more than the alveoli. So we have to distinguish, okay, if we see a pneumonia which is mainly affecting the interstitial space, the first thing which should come to our mind is a virus or an atypical pneumonia. But when we see the exudate is present inside the alveoli, you see a lot of neutrophils, you see a lot of things which are present inside the alveoli, whereas interstitium is relatively spared. We have to think of community acquired pneumonias. Having said that, we should be able to distinguish between the community acquired and the nosocomial pneumonias. Community acquired pneumonias are the ones which you actually get on the road when you are in the community, as the name says, so they are the ones which are basically affecting you when you are outside a hospital, whereas those type of pneumonias which affect a person when the person is admitted into a hospital is called as a hospital acquired or a nosocomial pneumonia. Why is it called as a noso? It has nothing to do with nose. I'm sure it is just because I have no idea why it's called as a nosocomial and why is it related to hospital acquired infection. But anyways, so we have community acquired pneumonias. So those type of pneumonias which are present, which you may get in the community, which you may get on the road, are called as the community acquired pneumonias, whereas the ones which you get in the hospital are called as the nosocomial pneumonias. Etiological agents, the host immunity, they should have a balance. Whenever the balance goes down, when they get strong, they get weak. When agents go strong, immunity goes weak, or any of these or both of these things happen, the patient will be predisposed to pneumonias. Two presenting symptoms, very simple. What would they be? Two presenting symptoms will be fever, because it's an infection, and second one will be cough. Yes, right. So they will be having fever and cough. Two diagnostic methods which are really important to diagnose these conditions. The first one would be blood culture, and the second one would be a chest x-ray. And here I would like to give this kind of an end note here, that any organism can cause pneumonia. Any organism, any microorganism basically can lead to pneumonia. The clinical spectrum of the disease may range from an acute stage to a chronic disease. So but this acute things will finally lead into a chronic disease sooner or later. Talking about the histological spectrum, there will be a lot of things which you may see in all sorts of pneumonias. You may see exudate, which is fibrino-purulent alveolar exudate. It means there is involvement of the alveoli. Along with, you see purulent, that means you have a lot of neutrophils, you have a lot of pus, you have a lot of necrotic debris going on. Then you have a lot of fibrin which has come here. When you see fibrin, that means we're talking about the exudate, right? When you say about the exudate, what is the second thing which you have to distinguish the exudate from? Yes, that's called as a transudate. Transudates are basically the ultrafiltrate, right? They are the ultrafiltrate whenever there is increase in the hydrostatic pressure within the blood vessel. So that increase in the hydrostatic pressure will cause ultrafiltration, and that ultrafiltration will lead to transudate. So it is just a filtration under pressure. So when you filtrate under pressure, you do not expect there will be no cells. There will be no cells, means no inflammatory cells. There will be no protein. Whereas in cases of exudate, what happens is, this is the capillaries. These capillaries will have inflammation, they will be damaged, the things will leak out. So they will have RBCs, they will have inflammatory cells, plus fibrin. Protein will come out, and if protein comes out, it will make it heavy. So when that particular fluid inside the alveolus becomes heavy, it means there is increased specific gravity, which will be more than 1.020. We have discussed all these things when we were talking about transudates and exudates during hemodynamics in the foundation block. Whereas in cases of transudate, the specific gravity will be less than 1.020, if you remember, right? So this is how you have to differentiate. No, this is an inflammation. So when it is an inflammation, you expect a lot of inflammatory cells, you expect RBCs, you expect fibrin, because there is damage to the wall. So when these things happen, it will lead to purulent alveolar exudate, mainly seen in the acute bacterial pneumonias. If you see mononuclear, that means only the chronic inflammatory cells, mainly the lymphocytes, you see macrophages within the interstitium. So we have infiltrates within the interstitium, mainly comprises of the mononuclear cells. We have to think of viral, as I mentioned earlier, or other atypical pneumonias. So we don't talk about acute bacterial pneumonias anymore. We talk about viral or atypical pneumonias. If you see granulomas and cavitation, they will be commonly seen in chronic pneumonias. Now this word chronic pneumonias, all the pneumonias are basically chronic. So we don't have any specific category called as chronic pneumonias. So this term is more or less a misnomer. But anyways, so those type of pneumonias which have granulomas, cavitations, we have a huge list again here. The common ones are tuberculosis, histoplasmosis, coccidioidomycosis. All these are the ones which may lead to chronic pneumonias, which comprise of granulomas and cavitation. Now, acute bacterial pneumonias, as we have discussed earlier, will have two anatomic or radiographic pattern, which is called as a bronchopneumonia and a Lobar pneumonia. This is how it is. This is a bronchopneumonia. You can see they have a focal pattern of involvement of the lung. They may involve more than two lobes. They may involve the whole of the lung, but this is a very patchy, it's a very patchy distribution which you can see here, as compared to a Lobar pneumonia. The whole of the lobe is affected. Now, having said that, if I say affected, what do you mean by the word affected? This part is affected, this part is affected. Here you can see this is pink, this is red, but that's not how the case actually would be in an autopsy. So if this is red, that means this part of the lung is having lots of exudates within the alveoli. This part of the lung will have lots of exudates within the alveoli. That means there is no air in this part of the lung. So when there is no air in this part of the lung, it is almost equal to a solid organ. Lungs are not solid organs, lungs are spongy organs. But if you see here, they will look like, they will appear as if they are solid organ, which is called as consolidation. And in reference to pneumonia, we also have a term called as hepatization. Hepatization, because hepatization means that they look quite similar to the liver. They feel, they on palpation, they feel quite similar to the liver. So in bronchopneumonia, you have a patchy distribution of inflammation which may involve more than one lobe, whereas Lobar pneumonia, part or all of a lobe is affected. We have a friend called as Streptococcus pneumonia who lives in your mouth as well. More than 20% of your oral flora comprises of Strep pneumoniae, Streptococcus pneumonia, which is a gram-positive diplococci, right? So this bacteria is present, is very commonly present everywhere, and it is the one which causes more than 90% of the Lobar pneumonia. So if you have to make a movie on Lobar pneumonias, so which hero will you cast? You will cast Streptococcus pneumoniae. That's the hero. And so we have given them a degree. We have given them a degree called as pneumonia, because they are so much expert in causing pneumonia. So we have given them a degree called as Streptococcus pneumonia. Now this is a list of classification of pneumonias. You have a lot of things which you can see here. They are community acquired pneumonias, you have community acquired atypical pneumonias, you have nosocomial or the hospital acquired pneumonias, you have aspiration pneumonias, chronic pneumonias, necrotizing pneumonias which may lead to abscess formation, and finally the pneumonias in the immunocompromised host. right? So these are different types of pneumonias. We'll be talking about we'll talk about all of these one by one in a short while. Now talking about pneumonia syndromes, we have different culprits now, who the etiological agents which we have to discuss. Community acquired acute pneumonia, we have community acquired atypical pneumonia. The ones which cause community acquired acute pneumonias are, now this again, this word acute, they're not really acute, they take a long time to develop, but they take a short time to develop, so that is why maybe they're called as acute. So you have Streptococcus pneumonia, as we have discussed, which causes more than 90% of the lobar pneumonia. You have Haemophilus influenza, you have Varicella catarrhalis, Staphylococcus aureus. They go together. Strep and Staphylo, they almost go together. Staphylococcus aureus is, if it is just a community-acquired pneumonia, but if it is a methicillin-resistant Staph aureus, or MRSA or MRSA, then it is more likely to be a hospital-acquired infection, and that may have a worse prognosis than just a simple Staphylococcus aureus. Then there is something called as a Legionella pneumophila, which once caused an epidemic of pneumonias at Legionnaire's convention. So this type of pneumonia is spread by droplets. There was something went wrong in the ventilation, and a few people died even in that convention called as Legionnaire's convention. So hence the name Legionella pneumophila. Haemophilus influenza is the type of bacteria which will cause pneumonias in young children less than 2 years. So whenever you have a pediatric patient less than 2 years comes to you with symptoms of pneumonia, then you may have to think of H. influenzae as the first etiological agent. Plus these bacteria can also lead to meningitis. They may also lead to otitis media. They also lead to osteomyelitis in young children. Varicella catarrhalis is again one of the bacteria which can be seen in patients suffering from chronic obstructive pulmonary diseases. Then we have a species called as Enterobacteriaceae species. We have Klebsiella, you have Pseudomonas species. Klebsiella pneumonia is commonly seen in those patients who are alcoholics, who are debilitated, who are malnourished. So if these words come, we have to think of Klebsiella. Pseudomonas is the one which is commonly seen in patients suffering from cystic fibrosis, which is a genetic disorder, again affecting the lung as well. So these patients are more prone to Pseudomonas species. Pseudomonas. Plus, if you see some kind of a greenish pus or a greenish exudate, you have to again think of Pseudomonas. So the things which can be closely related to Pseudomonas are cystic fibrosis and green pus. In Klebsiella, alcoholics, malnourished, debilitated people. Legionella epidemics, air droplet spread. Staph aureus and Streptococcus pneumoniae, they go together. H. influenza in young children. Varicella in patients suffering from other disorders like COPD and so on. Next, talking about community acquired atypical pneumonia. Again, we have one more bacteria called as Mycoplasma. Again, we give them a name called as, we give them a suffix pneumonia. That means again this is one which is the most important culprit in this category. You have Chlamydia species, you have Coxiella buntai, and then you have all these viruses. Now remember, atypical pneumonias are those types of pneumonias which will cause what type of exudates? The type of exudates will be in the interstitium. Yes, they will be causing exudate in the interstitium, whereas these types of pneumonias will cause exudates in the alveoli. So they will lead to alveolar exudates, whereas they will lead to interstitial exudates. The third category is the nosocomial pneumonia, the ones which are acquired in hospital setting. Let means the patient is already having some problem, and the problem is further complicated by nosocomial pneumonia. So we have a few species here, plus we have this methicillin resistant Staph aureus, also called as MR. What's happening? MRSA, methicillin resistant Staph aureus. Another type of pneumonia, the fourth type of pneumonia, is called as the aspiration pneumonia, which is seen in those patients who cannot really have a gag reflex, they cannot really cough, the ones who are in coma under effect of alcohol, under the effect of anesthesia, and so on. So these are the ones which will be aspirating the gastric contents, and when they aspirate the gastric contents, it will lead to infection of anaerobic as well as aerobic bacteria. At the same time, you will also be seeing, if you take a histological section, you will also be seeing the gastric contents. You may see some vegetative material in the histological section of the patient suffering from aspiration pneumonia. Now we have chronic pneumonia, which may be caused by nocardia, actinomyces, or which may lead to granulomatous inflammation. For example, that the chief here is the Mycobacterium tuberculosis, coccidioidomycosis, histoplasmosis. Infections, lung infections, which may lead to necrotizing pneumonia, and finally lung abscesses. The main culprits are all anaerobic bacteria. You also have Staph aureus, Klebsiella pneumoniae, Streptococcus pyogenes, types pneumococcus, and so on, which may also lead to lung abscesses. Pneumonias in the immunocompromised host, the last category, is caused by relatively usual bacteria, unusual bacteria, causing which may lead to disease. So all those usual bacteria, viral, fungal organisms which are present around you may lead to pneumonias in the immunocompromised host. Again, so we have Streptococcus pneumoniae, HAEMOPHILUS influenza, also called as H flu, Moraxella catarrhalis, Staphylococcus aureus, Klebsiella, Pseudomonas, and finally Legionella pneumophila. The classic lobar pneumonia, as we have discussed earlier, a lobar pneumonia, which affects whole or part of the lobe. Lobar pneumonia, if we have to make a movie, we have to cast one hero called as Streptococcus pneumoniae. Yes, so they are the one which cause classic lobar pneumonia. But as I told you earlier, remember, as I said, that it's very difficult to differentiate sometimes. We cannot say that this bacteria is the one which is always going to cause lobar pneumonia, or this bacteria will always lead to bronchopneumonia. So Streptococcus can lead to lobar pneumonia, at the same time can also lead to bronchopneumonia. It is one of the normal flora in our nasopharyngeal cavity. Around 20% of the adults will have this, as only 20% of the patients or victims will have a positive blood cultures. Penicillins are almost always curative, and vaccines, we have the vaccines for the Streptococcus. They take the capsular antigen and they prepare vaccines out of it. So and these are almost always 100% preventive. If we talk about children, as I said earlier, if they're less than 2 years, the main culprit will be Haemophilus pneumoniae. They may present with otitis media, upper respiratory tract infection, meningitis, cellulitis, osteomyelitis. So pneumonia in children which who are less than 2 years is considered by H-influenza until proven otherwise. This is one of the most common pneumonia seen in adults who are suffering from COPD, and we have a wonder drug called as Bactrim, which is combination of trimethoprim and sulfamethoxazole, which is one of the most common and quite a successful treatment of H flu pneumonia or Haemophilus influenza pneumonia. Yeah. Now coming to the pathology part of the pneumonia is when we have to discuss the spectrum, the anatomic or the radiographic spectrum of the pneumonias. Talking about lobar pneumonias, they are the ones which will involve the complete lobe or may also involve more than one lobe, 20 to 50 years This is the common age group. Adults mainly are the ones who get affected, and the main star cast is Streptococcus pneumoniae. They have been classically divided into four stages. The pathology of Lobar pneumonia has been classically divided into four stages. We have stages called as congestion, red hepatization, gray hepatization, and finally leads to resolution. So these stages are no longer seen so often because of advent of a good antibiotic therapy, good diagnostic modalities, and all these things have really helped us to curb these stages, and we don't really have these stages anymore. But it is an important thing to discuss when we talk about pathology. So these four stages of congestion, red hepatization, gray hepatization, resolution are the ones which we should be discussing now. Here we have a specimen of the lung which shows two lobes, so it most likely is a left lung. You can see this part. So which part is the one which is having consolidation or is involved? Yes, the lower part is the one which is having consolidation, because upper part you can see is still spongy, it's still glistening. You can see it's quite shiny over here, whereas this part is very dull, it's no more shining at all. And you can see the whole of the lobe and have a nice demarcation zone which is basically demarcated by the fissure. Yes, the fissure of the lung is the one which is demarcating these two lobes, and you can see this part of the lung is completely affected. Affected means the alveoli are occupied by the exudates. They will have less crepitance, they will have less lucency. So if you take an x-ray, this part will appear quite white on an anterior posterior view of a chest x-ray. So congestion starts within 1 to 2 days. Congestion, as we have understood earlier, congestion means increased amount of blood in that particular area. So when there is congestion which starts in 1 to 2 days, the affected lobe will definitely be heavy. You have more blood, you will have more water which is going through that. So the affected lobe will be heavy, will be red and boggy. Boggy. How do I explain what boggy is? Boggy is when you fill a balloon with water, half fill it, it's not completely full, it's not so tense from the outside, so you have a boggy feeling of that particular balloon which is half full of water. The vessels will be congested. You will see the proteinaceous fluid present in the alveoli. From where does this proteinaceous fluid come? This proteinaceous fluid definitely comes from the capillaries, right? The capillaries which are present in the interstitial space of the alveoli. This proteinaceous fluid will leak out. So if the fluid leaks out which contains protein, we will call it transudate or exudate. Yes, we will be calling it exudate, right? We will be calling it exudate because the amount of protein will be high, it will be heavy, it will also have neutrophils, it will have bacteria. So this description is quite close to an exudate. So you will mainly see the exudate within the alveoli. So the normal air within the alveoli is replaced by the exudate. So if we see it broadly, all these small alveoli are now being filled by these things. So definitely the lungs will be having a hepatization which will be initially red, which is called as a red hepatization, which starts within 2 to 4 days. Alveolar spaces will be full of neutrophils, red cells, and fibrin. Fibrin is the protein which now comes out. The third stage is the stage of gray hepatization. Slowly these RBCs will be ingested by the macrophages. So these macrophages will remove the RBCs, they will remove the neutrophils, and finally you are just left with a fibrinosuppurative exudate inside the alveoli without red blood cells. So you have the same thing, the only thing which is missing here are the red cells. So you have a stage of called as stage of gray hepatization, and finally you have a stage of resolution. The exudates will be digested enzymatically, and finally they will be degraded into granular semi-fluid debris finally, and they will either be phagocytosed by the macrophages, they may either be coughed up, or they may get organized and stay there forever. Organization means they are healing, they have healed with formation of a scar. We'll see a diagrammatic representation of all these four stages. Stage of congestion, called as the initial phase, starts within 1 to 2 days. The lungs are enlarged, heavy. There is mild inflammation of the pleura, which is called as mild pleurisy. You may see, if you see the histological section, because of increased amount of blood inside the capillaries, there will be edema in the alveolar space, which will cause widening of the septae. You will see some polymorphonuclear leukocytes or neutrophils. You will see some RBCs. So because of increased congestion, because of inflammation, things will leak out, and those things are RBCs, those things are neutrophils, those things are the fibrin protein. So this is presence of exudate. The second stage is the stage of red hepatization, also called as early consolidation. This part of the lung is affected. The lung is red in color. When you press it, when you palpate it, it will be quite firm, and you can see there will be presence of a serofibrinous exudate over the pleural surface. Now what has come here? You can see lots of neutrophils, you can see lots of RBCs, plus lots of fibrin strands. They will again replace the air, and they will occupy the alveolar spaces. You can see a lot of polymorphonuclear leukocytes and RBCs and fibrin which is present in the alveolar spaces. Third stage is called as stage of gray hepatization, which is also called as a late consolidation stage, which lasts for 4 to 8 days. The lungs are firm and gray. You will see instead of serofibrinous, now you have only fibrinous pleurisy. Macrophages will mainly take over. RBCs will be digested. Fibrin is quite dense over here. Polymorphonucleocytes are not as many as they were in the previous stage, and you can see a stage of contraction. You can see they have been contracted. There is a clear space between the exudate and the interstitium or the alveolar walls. So there is contraction because of presence of this fibrin, which has now contracted. The final stage is the stage of resolution. See, it has almost come back to normal. You will see a lot of macrophages, you will see congestion, and you will mainly see lymphocytes. So this is how congestion, this is how a resolution will look like. The things which are present in the exudates have finally been organized into either fibrosis, or they might completely be coughed out if it's not a very big area of the lung which is getting involved, or it may completely get digested with the help of enzymes present within the alveoli. Now when everything of such sort happens, of course it will lead to some kind of complication. The major complication is formation of an abscess. When the bacteria is having a high virulence, it leads to a lot of tissue destruction, it will lead to necrosis, and finally will lead to formation of an abscess. When this thing leaks into, for example, you have exudates which are present. Let's say this is the lung, this is the pleura, which is here. So this part of the lung is the one which is involved. Now this may even leak into this pleura, and when this pus, when this pus leaks into the pleura, this is called as empyema. So presence of pus within the pleural space is called as empyema. That can happen when there is extension of this particular inflammation, or this, let's say wherever inflammation it comes into the pleural cavity, it will lead to formation of empyema, or it may lead to complete solidification of that portion of the lung because of organization, because of fibrosis. So that part of the lung becomes almost useless, right? So that part of the lung become completely useless. This is called as consolidation. There may be dissemination of inflammation by hematogenious route, and when it comes into the blood, it may go into the brain and can lead to meningitis. It may go into the joints and may lead to arthritis. It may go into the walls of the heart and may lead to infective endocarditis. Right, so these infections may spread, and these are the complications of these infections. Now, a nice chest X-ray which you can see here. So what do you see here? A lot of people during my lecture, a lot of you they mentioned that this is involvement of the upper lobe, right upper lobe. We should not comment. We have always been told during our MBBS days that we should not comment on the lobe based on the X-rays until we have the 3D, because upper lobe is mainly posteriorly, right? So you cannot really see, you cannot really, it can be a middle lobe which has reached all the way till the apex. So yes, if you say this is the right upper field, the upper right field of the lung, which is having consolidation, you can see it's completely consolidated, yes, we will be very happy. So be careful when you commit the type of lobe on a chest X-ray. This is the part of the lung. You can see this part is still spongy, whereas this part of the lung shows solidification. This is completely solidified, and it is very nicely demarcated with a fine line, and that fine line is nothing but lungs fissure. You can see histology. You can see these are the alveolar exudates, which are full of if you take a high power zoom, and you will if you zoom in, you will see a lot of neutrophils. You will see a lot of RBCs. All these red orange color things are basically RBCs. Plus you can also, but if you look very carefully, the alveolar septa are still maintained, you know, it's still, you can still see the outline, though they have been affected by the neutrophils over here. Slowly this infection may even reach into the interstitium, right? So it is not only that if it's interstitium, it means viral or atypical. If it is bacterial also, it will start in the alveoli and may finally lead to the damage of the interstitium as well, and may lead to formation of a large accumulation of neutrophils, which is called as an abscess, right? So now if you see here, what I was trying to tell you here, if you see the alveolar boundaries are still intact, that means the virulence of the bacteria is not much. The bacteria is not virulent enough to cause damage of all these septae. The septae are still intact. Yes, they are being infiltrated by the inflammatory cells or even maybe by the bacteria, but still they are intact because the virulence. If the bacteria is really virulent, if it has very high virulence, or if the host immunity is really down, it may even lead to damage to these septae. You can see a lot of neutrophils, but you can still manage to see the alveolar septae. So looking at this, we can say that the bacteria is not so virulent. You can see these diplococci, gram-positive diplococci, which are present here. These are the gram-positive diplococci which are present in the smears. Now the next anatomic classification of pneumonia is called as a bronchopneumonia, commonly seen as a terminal event in a chronic disease. Patients suffering from diabetes mellitus, hypertension, renal failure, they may suffer from bronchopneumonia. They're common in the extremes of the life, in infancy or in the old age, or they can be manifestation of a secondary infection. The inflammation spreads from the terminal bronchiole to an alveoli. This will not involve the whole lobe. This is going to have a patchy distribution, and that patchy distribution is because it is spread from the terminal bronchiole to the alveoli. So this is going to be patchy as compared to the lobar pneumonia, which is going to be a diffuse pattern. So you have patchy inflammatory consolidation. They are mainly bilateral because both of the lungs may be involved, mainly basal. They are well developed lesions, 3 to 4 centimeters in diameter, slightly elevated. If you feel the surface of the lung, they will be slightly elevated, gray, red to yellow color. The borders and the surface of that particular area, of the involved area, will be hyperemic and will be edematous. Pleura involvement is less common. Having said that, why pleura involvement is less common? See, lobar pneumonias are going to affect this lobe or any lobe. So the whole of the lobe is involved. When whole of the lobe is involved, you cannot really expect the pleura to be spared. So pleura will be involved. Whereas in cases of these bronchopneumonias, which will have a patchy distribution, you don't really expect the involvement of the pleura. So pleura involvement is less common in bronchopneumonias. In bronchopneumonias, you have less pleural involvement. Of course, in lobar pneumonias, all the alveoli in this zone will be having exudate, whereas in this case, these particular alveoli will be having focal suppurative exudates, which will fill the bronchi, bronchioles, and even the adjacent alveolar spaces. The final resolution, the final sequel, the final thing can either resolve. They may have patchy scarring, and really they may even lead to a lung abscess. This is how you can differentiate between lobar pneumonia and bronchopneumonia. We have a lot of categories under which we can easily differentiate between lobar pneumonias and the bronchopneumonias. You can go through the list. Viral pneumonias, if you can see here, it mainly affects the interstitium, whereas bacterial pneumonias are the ones which will mainly affect the alveoli. So if we are talking about interstitial pneumonias, it means we are talking about either viral or the atypical pneumonias, which is mainly caused by Mycoplasma pneumoniae. We'll be discussing that too. I want to tell you here that all interstitial pneumonias are either viral or atypical, right? So all atypical pneumonias will be, of course, again be caused by viruses, and they will mainly be affecting the interstitium, whereas bacterial pneumonias will mainly be affecting the alveolar zones. Aspiration pneumonias will be seen in those patients who are unconscious, the patients who are on a prolonged bed rest, patients who have lack of ability to swallow or have a weakened or absence of a gag reflex. So they are usually caused by aspiration of the gastric content. So if you happen to see biopsy of a patient suffering from aspiration, or autopsy patient who has died of aspiration pneumonias, you will also be able to find some vegetative material. Some vegetative material will be seen in the biopsy. They mainly affect the posterior lobes. Why posterior lobes? Because they are gravity dependent. But no, gravity dependent, it should be the basal lobes. Why posterior lobes? Posterior lobes, because the patient is most likely lying down. The patient is bedridden. So these bedridden patients, the basal areas will not be gravity dependent. The gravity dependent areas will be the posterior lobes. Posterior lobes are the ones which will be gravity dependent in these patients. So the most commonly they will be involving the posterior lobes, especially the superior segments of the lower lobes. These are the segments which will mainly be affected if a patient aspirates something from the gastric content, and they will often lead to abscess. This huge abscess, which is the font is really big because the abscess may really be bad. You can see here this patient, you can see involvement of the lung, you can see consolidation over this zone, plus at the same time you can also see some patchy areas of consolidation here and there, and you can see a lot of EKJ wires. That means this patient was lying down, the patient is terminally ill or whatever. So with this we end our presentation. Lung abscesses will be taken up in the next presentation. Thank you so much for your time.